welcome everyone to session 2B, Mashed versus Meshed, integrating psychosocial care into your RAAM with Jared Bonis, Alyssa Scichilone, and Michael Roach. I'm your host, Josh Richardson. I'm a psychotherapist with Grey Bruce Health Services. I just want to remind everyone that there will be time for questions and discussion in the last 15 minutes. Please put your questions in the chat. And if you need any help during the program, just tap on the help button there to your bottom left. I'll be putting a link to an evaluation in the chat as we finish about the session. And there will be another evaluation you can fill out for the day of the conference as well. Jared Bonis is a nurse practitioner with a focus in addictions medicine. Prior to launching and managing his primary care practice in 2018, he worked as an ICU nurse in the CVT and medical surgical ICU setting. Given the need for substance use management in primary care, he developed a special interest in substance use to work toward providing additional access to addiction services in the rural primary care setting. He has experience providing addiction services in the acute care, community, and ER settings, as well as in medical withdrawal management and in the residential inpatient treatment setting. He has held previous leadership roles working in the creation and implementation of community-based addictions treatment programs. He currently practices as part of the Health Sciences North Addiction Service in Sudbury. He is an advocate for de-siloed, patient-centered care through the utilization of synergistic collaboration between allied health, medical providers, and community partnerships. He is a contributing author for the PHI Withdrawal Management Services Manual and currently chairs the Northeastern Ontario Nurse Practitioners Addictions Services Community of Practice. Alyssa Scichilone graduated from Laurentian University in 2020 with an honors bachelor in Indigenous social work. She began working in the mental health and addictions program in 2020 and joined the withdrawal management service Safe Bed program, a 24-hour voluntary service that offers short-term residential support to those who are experiencing a mental health and/or addictions crisis. Alyssa currently works with Outpatient Addiction and Gambling Services, OAGS, providing outpatient treatment to those with drug, alcohol, and/or gambling or gaming problems. And Michael Roach is the Northeastern Ontario Regional Lead for Addiction Services, including RAAM clinics and the Addictions Medicine Consult Service. In addition to providing regional leadership, he is also the manager for Sudbury's RAAM clinic and Outpatient's Addictions Gambling Service. Mike led the implementation and spread of the Health Sciences North AMCS through the hospital. He's a registered nurse with a varied background in education, nursing regulation, mental health, long-term care, community health, and as a school nurse in London, England. Mike is actively involved in research and scholarship, participating as an investigator in multiple research studies and publications. He also has a strong background in program evaluation, having worked as an education and program evaluation consultant for the College of Licensed Practical Nurses of Manitoba. And without further ado, here you go.
Thanks so much, Josh, for that fantastic introduction. As was really mentioned, my name is Jared Bonis, and I am one of the lead prescribers for the HSN Addiction Service Program in the RAAM clinic specifically. And to discuss our disclosures, we did not receive any external support for the creation of this talk. In terms of presenter-specific disclosures, as you can see here, we all work for Health Sciences North Addiction Service, but otherwise don't have much else to disclose apart from Mike, who did have honoraria for PHI. I think it was a couple of programs or advisory committee, if I'm not mistaken. So in terms of mitigating bias, we're not really discussing any medications or things like that today, but feel free if you have any questions or concerns to voice that. I'd be happy to speak to it. So we'll begin off with just a quick poll question, just to get a sense of who's in the room today. So if you want to quickly turn to the polls and just note your role there. with the team. And we'll just give it 30 seconds or so and then look to continue on. Okay. All right, I'm not sure. So it looks like I have a bit of a blend of a lot of different roles here today, which is great. To start off the conversation, I think that there's a lot of existing bodies of evidence and literature out there, specifically about substance use and trauma. And I think it's a generally acceptable statement to make that there's a very widespread, pervasive reality of clients who have substance use and a concurrent trauma diagnosis, whether it is substance utilization across the spectrum or research done into overlapping concurrent disorders. I don't think it would come as much of a surprise to anyone about the overlap of trauma and substance use. And at least in our own community, it might be similar for many other communities. A lot of times there are agencies or communities that offer some form of counseling service for substance use or mental health. But there's often also a direct siloing of care between the services just by nature of how they're being delivered and who's delivering them. So it might be through a counseling organization or a mental health organization or an addiction organization, but a lot of times they're very different organizations. And this is often for a very legitimate source of reasons: funding letters, organizational mandates, healthcare personnel, various leadership priorities. They all come together to create this program that they're going to offer, but a lot of times this means that the services are, by definition, going to be siloed because they're delivered by a whole range of providers in different organizations. So a lot of times this can create challenges for clients we're observing in our own practice here in Sudbury for how they access care and what that care looks like. So if they're looking for that holistic wraparound care experience, often it can be a challenge, and it also can have implications for their stabilization as well, because often what they're needing, or clients are telling us they need to stabilize from substance use perspective, solely, is a lot of times very much integrated with their other spheres, such as their mental health, their socioeconomic status, the determinants of health, their case management needs, as well as their substance use needs. And if substance use, in some courses I've attended or lectured I've been, it's been put forward as a primary, secondary, tertiary disease, then I would also suggest that management considerations need to evolve to reflect the nuances of the care needed and what that'll present as, depending on how the patient is moving through the system and accessing it. So to use a completely medicalized analogy, a lot of times it feels like the ambulance goes to the car crash and picks up the patient, as it were, and then takes them to an orthopedic surgeon for their broken leg. And then after they see the orthopedic surgeon, they get loaded back up and go across town to a general surgeon for a consult on a liver laceration before going to see a neurosurgeon for their altered LOC. And then they get in line for 9 to 12 months to wait for a psychiatry consult to tell them that they shouldn't have been driving when they're in an acute manic episode, rather than taking them just strictly to the emerge. Now, of course, we would never do that in that kind of example, right? Of course, we'd take them to emerge, and the whole team would come there, and they would have 3 or 4 consults in emerge. We'd quickly stabilize their situation, or try to, and then refer to the other services that were needed. But often we were finding for our own practice, at least in our setting, sometimes it wasn't that easy. The patient had to move from one service for a couple of months to then another service for a couple of months, and it was hard to get people to those services all simultaneously, and then a lot of times harder to help them stabilize with their trajectory of care, because there were other parts that were directly sometimes not as easy to address as other things. So moving over to Alyssa, we got specific feedback from some of our clients, and Alyssa's going to outline a little bit about what we were hearing from clients as they were seeing that problem play out in their day-to-day lives. Alyssa.
Thank you, Jared. So like you said, what has this looked like in our setting? Well, as Jared said earlier, we are coming to you today with an incomplete plan, but a presenting complaint that requires an approach to care as often lacks a clear, immediate solution. So at first, we were somewhat concerned about using the quotes until we realized that there was so much overlap that it could literally be said about any majority of our patients after just even going to one group session, a safe coping session, let alone the thousands of people that we serve each year. So essentially, what we heard from our patients is what was that the rapid prescription or the referral was truly critical for them. But without access to supports and treatment for the reported trauma or a clear pathway to deal with their mental health in meaningful ways apart from ongoing substance use to deal with the life they go home to. Everything we are doing is basically all just a harm reduction and meeting them where they're at in terms of their journey. So following that, whether it's the data brought forward in the ACE study, substance use focused research into concurrent trauma, or the general body of mental health literature commenting on the overlap between substance use and mental health. So there is an overwhelming body of evidence that does show that trauma and concurrent mood consideration in settings of substance use, and with the combination of biological and psychological and social factors that can contribute to why a person may be struggling with an addiction or substance use. And for those who have attended trauma seminars or certain psychotherapy approaches, we've probably all seen the iceberg picture or the iceberg trauma picture in the slide here. And while I wish to make all the same points, I wanted to draw attention to the extension of that classic metaphor, and which is that the iceberg can rotate, but sometimes even flip over in the water, though often not the really big ones because of their size. But this can cause a huge tsunami like waves, which can pose a significant danger and barrier to accessing those social determinants of health. They play a significant role on a person's overall well-being and can impact the addiction or substance use related issues. So what happens when our patient's substance use at the surface starts to rotate and all other things start coming to the surface? So classically, this has been a strong point of caution for triggering our patients and not having that safe space discussing the trauma or allowing them to have that space or in the deep counseling. But however, in our patients are to believe their substance use is how they keep their own life from flipping over, and they cope the best they can or feel that they can at that time. So essentially, while critical to clients' care, medication is only a part on how patients can cope. However, it's not going to teach each client how to play the hand they're dealt, even if we try to deal with them in a few new cards. So in fact, it could also be argued that we are asking these individuals to give up their most reliable short-term coping strategy, and when we try to help them change their patterns of substance use. So at its simplest, if RAAM clinics exist to rapidly help people start a plan of care for their substance use treatment and be able to provide the access to healthcare providers who can do that for them, then we want to clearly embed that psychosocial care and to mesh it into that client care experience. However, as maybe many of us have felt in the past or going through now, it does turn out it is a lot harder to do than say, but the team is growing, and the imperative, it's defining, it's deafening, and we're hearing all the concerns, and we're trying to look at our team and see how we can use our team as best as we can. But I will move this to Michael.
Thanks, Alyssa. So I'm going to spend a little bit of time talking to you guys about the current setting and realities for care in Sudbury, Ontario, as well as some of the trends that we've been seeing throughout the Northeast. Next slide. I do have slide control. Apologies. So where are patients coming from? On the slide, you can see the referrals that we've been receiving to our RAAM clinic categorized by service area. We have had some dramatic changes in our trends throughout the COVID-19 pandemic. Specifically, the biggest areas that we've seen changes in are our mental health and addiction service referrals and self-referrals. For note, it's important to realize that that yellow bar is for 2022, 2023, and only consists of our Q1 referrals. So to keep in context, when you're looking at our self-referrals for the entire year for 2019 and 20 is almost as much as we had in our first quarter of 2022-23. Now, the majority of our clients are now coming through self-referral, and this is for lots of various reasons. One, a lot of our clients are hearing through word of mouth. We're getting a lot more of our promotional materials out there, so cards that have our phone number. And we're also getting a lot of people directed to us through healthcare providers within the hospital. On the other hand, our mental health and addiction service referrals have been reducing throughout the pandemic, as have our emergency department referrals. Now, with our current human resource crisis, our current situation in the hospital, and people being unfamiliar with what agencies are and are not open in our communities, we find that a lot of people are being handed information, and from that point going on and requiring to figure out the system on their own. So what substances are we seeing? So this is pretty consistent throughout the Northeast. The majority of people coming into a RAAM clinic are seeking assistance with alcohol use disorder. It has been that way since our programs launched, ours in 2016, and the others in the Northeast throughout the following years. We also see about 19% of our clients with opioid use disorder. Again, that's been fairly consistent throughout the last few years. A newer trend is that about 18% of our clients are coming seeking assistance with stimulant use disorder. So we're seeing a lot more individuals using stimulants as opposed to the larger percentage being alcohol, which was the case prior to that. In regards to our region, we have dramatic opioid-related deaths when we compare ourselves per capita to the rest of Ontario. So as a region, the 4 of our 5 public health units had the top 5 per capita rates in 2020 and again in 2021 related to opioids. Sudbury, Algoma, Porcupine, North Bay, we all consistently have very, very high rates of opioid-related deaths. The other important fact that you should be aware of is that although we only make up about 6% of the population of Ontario, when we look at the deaths per 100,000 people, in 2020, Northern Ontario made up 30% of those per capita deaths when compared to the rest of Ontario. So it isn't just opioids that are a concern in our region. As I mentioned, the use of stimulants is constantly increasing throughout the Northeast, and stimulant-related deaths are also on the rise. So the majority of these are mixed with other substances, and which has been consistently the case throughout the COVID-19 pandemic. So this slide here is demonstrating the impact on our healthcare system. We have large numbers of people coming into our emergency department and into our inpatient beds, in addition to the deaths. So again, a lot of our numbers are staggeringly high when we compare it per capita to Ontario. Sudbury ourselves having 259.9 people coming to the emergency department in 2020 compared to Ontario at 84.6 per 100,000. Our hospitalization rates are also continuing to increase, putting increased pressure on our inpatient beds throughout the hospital. So this here is HSN specific data that is showing what is happening within our system. So we are seeing increases in visits to our emergency department year on year, with 2017 last fiscal year. Our medicine beds are also seeing increased rates of individuals being admitted with substance use disorders, up to 1,126 last year. And our psychiatry units actually saw a decrease in numbers. It really, what that comes down to, or what we're attributing it to, is the launch of our addictions medicine unit, which is that smaller bar graph to the far right. That unit opened up in 2021, and we do tend to see a lot of individuals for a psychiatric unit in that area. One of the more interesting and perhaps alarming trends is the number of individuals being discharged from our hospital's emergency department with a substance use concern is actually going down, meaning that more people are being admitted to our hospital, which anecdotally is demonstrating the number of individuals showing up to our emergency department who are extremely sick, and our healthcare providers not knowing where to send people, requiring an admission. And lastly, I think the other important fact to note is we are seeing increased rates of opioid use disorders arriving at our emergency department. We are seeing high rates of opioid poisoning, but alcohol use disorder still weighs a heavy toll on our emergency department. Showing that far bar graph to the right demonstrates the number of people who have been arriving at our emergency department related to an alcohol use disorder. Lastly, before I pass it over to Jared, I just thought I'd show you a little bit of our outpatient numbers. So the bottom bars on the very low area there would be our RAAM numbers, and our RAAM numbers are increasing every year. So from 2019 to 2020, we saw more clients than we had seen in any year previous. A lot of our other inpatient units actually saw reduced numbers throughout 2019-20 and 2020-21, and that, 2021-2022, and that is mainly related to restrictions put in place by the COVID-19 pandemic. A lot of our sites had suffered from reduced numbers due to isolation requirements, redeployment, and all kinds of other restrictions that were put on our environments based on isolation requirements. However, our RAAM remained open and accessible and continued to see clients as best as we could throughout the pandemic. I'm now going to pass it back over to Jared.
Thanks, Mike, for that lovely segue. So then how did that play out and what our clinical picture was looking like? And we realized that without a comprehensive wraparound plan, vulnerable patients just continue to be exceedingly more and more vulnerable. As Mike was saying earlier, more people coming to the hospital, sicker, more complicated cases, which I think might be, reflective of what a lot of people are seeing across the board, but we were really seeing it here, and it's taking a very big toll, or remains to continue to take a big toll on health human resources and capacity resources, because the system is inevitably, tasked with solving more and more complex problems as patients look to access services, and a lot of times the only way they can get that, wraparound seen by the right people, as it were, is presenting to emerge. And then often that just creates a cascade of implications on very scarce health human resources, as well as for the patient themselves. So the biggest question then we were left with after all that was, so then how does our model of care, what we're currently doing right now, bend and adapt to where the clients are telling us their need is. And one of the biggest things we were hearing is that need for, yes, starting medications, getting that referral, but having a way to engage with psychosocial supports for all the other things that were going on in their lives as they were trying to cope, and as their substance was in many cases being used to help patients cope with a lot of other things. So from that, this is our team here. We've got 2 registered nurses, one of which serves in a charge nurse capacity, and 4 social workers, one of which is also backfilling for an intake worker because we only have 1 RAAM navigator. And we have 2 kind of management roles, but only 1 clerical for the entire team. And then we have 2 physicians providing consultations, Dr. Bagavatula, excuse me, and doctors Lionel Mark Chabris providing consults for the clinic as well. Dr. Bagavatula being one of our staff psychiatrists with an addictions focus, and Dr. Mark Chabris being with us as well from a chronic pain perspective. So essentially, with that team, we came to this moment where we raised this hypothesis saying, if we could collaborate and combine more effectively in the delivery of service and amalgamate our psychosocial arm of programming with our rapid access addictions medicine aspect, we can, perhaps decrease the demand on either program, because then patients aren't waiting to do one or the other. They're trying to do both simultaneously. So that is through our outpatient addictions and gambling service, of which Alyssa and I are colleagues through that, or OAGS, and the rapid access addictions medicine program. And the thought was, by embedding that partnership right into the get-go, can we help patients, right off the hop from that very first visit, to be able to access those key components simultaneously, because traditionally there can be, months of wait lists for psychosocial support. The cost can be prohibitive for some clients, and there can be a whole realm of barriers that they have to circumvent themselves sometimes, while also trying to stabilize on their medication. So we looked at some of the key barriers we were facing and said, okay, what would it take? Where do we want to start? Because it's not just as easy as, saying, let's amalgamate 2 programs and try to mesh together, RAAM with psychosocial programming. What'll it take? So we started off saying, okay, well, how are our clients going to get to us? And then once they get to us, what resources are we going to connect them to, and what will that process look like? And then what are the procedural or systemic or kind of organizational barriers that we ourselves will have to troubleshoot as we start trying to offer these, simultaneously, or as, in fact, one care experience? What will it take? So just looking at the access to care side of things, so often, at least in our paradigm, system reality dictates that there will be care siloing. And this is despite the fact, I think there's a lot of evidence to suggest concurrent management is really a key priority. So rather than having to have the patient go to the most acute level of care to get that whole picture, what can we do in the community or the RAAM setting to start offering that that holistic approach, by making sure that they can just come through one community setting and be able to access that psychosocial and medical side conjointly at the same time. The second kind of consideration was, how do we want them to make the connection with our service? And it was kind of a paradigm shift, between making our patients kind of wait to get picked up by the next, car coming along, as it were, the next service or next program in the queue, to actively going to them to offer services and say, here is this body of services that we want to offer to you concurrently. So there was opportunity to do, in-reach to the hospital, to try to partner with other collaborative organizations in our community, so that patients or clients can have that kind of one-stop shop experience, if you will. And it doesn't mean they'll be interested in all of them at the same time, but at any point they can be tapped into any of the other aspects, as opposed to having to, systematically or chronologically move through. And lastly, as I mentioned, earlier, the other question was, systemic barriers. And the truth is that, as I'm sure we all know, we can't control funding stipulations, data metrics that are required for reporting, and there are kind of rules, if you will, that you have to follow by nature that you're running separate programs. But can we control perhaps how our client sees that? So maybe they're not seeing different processes running in parallel. They're seeing just one process, which is how they get to their care provision as we do the background work. And while we can't control various mandates for other programs, we can have a very clear collaborative mindset to promote warm handoffs and client kind of care navigation to hand them off to one another, as opposed to just simply moving them along to the next step or next queue. So what did that look like in a very tangible way? Oh, I think I'm in full screen mode there. The first thing, is we wanted to look at time. When a person comes through to a RAAM appointment or a psychosocial appointment, rather than saying, okay, well, you're actually looking for medication, so we'll, shuffle you off to another place or book another appointment. Is there a way to maximize that by having the teams working side by side? So that's something we're actively doing right now. So it's meant actually less provider prescriber time, because you can tack on to the back end of a psychosocial appointment and be sharing those appointments, so the patients can have their time kind of utilized as one care experience rather than sequential visits. The second thing was patient appointments. So leveraging a small team with different roles so that they can routinely have appointments with their addiction service rather than with one particular person, and shifting a focus from, this is my worker or my, my case manager, my prescriber, to saying, this is my team, and I'm going to be able to have actually more follow-up, but not with the whole team, even though they're going to be talking about me in huddle the next morning, to ensure I'm getting all these different pieces. And this led us really to make the argument for combining, our psychosocial arm with our RAAM arm, so we could have that more seamless integration of care. And then the third thing was looking to optimize how we do communication between teams, because as soon as you try to communicate between two different programs, that can create, challenges. And that's been through having shared communication and kind of shared documentation and information storage, so that people can have access to the information in a real-time way. And then the other thing kind of leads into it is information access. So really trying to embrace digital utilization of technology, so you can have real-time records and contact with your colleagues, as opposed to having downtime for documentation and traditional kind of routes, which allows then for a better coordination of service, we're finding, because patients can be, following up with the team in their psychosocial appointments as well as with their medical appointment, and coordinating between those two arms more seamlessly. So what's been the initial feedback as we've looked to kind of introduce those various changes? And I'll turn it over to Alyssa to talk about some of the implications for patients and providers.
Thank you. Kind of echoing what Jared was saying, what we're hearing from our clients is that they have in the past, or if this is new to them to treatment, they have experienced being shuffled from different services because of the substance use. They seem it can prevent them from accessing other resources like mental health resource, trauma work, because of the substance. And they're finding themselves jumping through those hurdles at the end of the day. But it can be very frustrating at times with the wait for community services, or being at the wrong door answers, or once they get into that door. There is a recognized shortage of community resources with the impacts from the pandemic and short staff shortage with extended wait times. But however, that being said, when they do get into the door, they are happy to have that clear pathway to treatment and not having to repeat their stories multiple times. By having that collaborative, integrated team approach, their needs are being met at the time at their first initial contact. And oh, here we go, I got control. So that being said, for the feedback we've been getting from myself and staff members, what they've liked and what's worked, what hasn't worked, we've been seeing great putting into that interdisciplinary approach in our team. So with OAGS, the Outpatient Addiction Gambling Services, and the RAAM clinic, versus that multidisciplinary being able to just Teams one of our colleagues for a quick consult, or having our team role utilized, and better patient navigation. And we've been having better communication with client engagement, as Jared was saying. Some things that we, as we know, we're trying to learn that interdisciplinary team. We've been seeing some duplication of processes, communication we're working towards. Sometimes it's not clear, but we're able to, with the demands of seeing more the psychosocial piece, and with our team growing, we are looking for more high-depth training to be able and to be prepared to treat these individuals as needed. So more training into maybe CBT training, or conducting Gains Q3 to help referrals to residential treatment for these clients. So the need of looking for more training to best serve our client population. And so I will let Jared continue.
Actually, me, I will jump in. Thanks, Alyssa. So from a systemic perspective, the conversation that I have been part of and continue to hear is that there is a need for a model similar to what we're trying to build. So stakeholders are identifying the need for concurrent treatment, both medical and psychosocial, for the clients that they're seeing. So what we are trying to do essentially is provide a model where our two teams can work together as one team to provide that concurrent treatment. Systemically, what we're hearing is a lot of people who are see the need, but not quite ready to make those next steps, mainly due to things like capacity, resources, those types of things, which is requiring a lot of people to have to look for collaborative approaches to concurrent care. At Health Sciences North, because of this need for a collaborative approach to care, partnerships are continuing to occur with our internal programs and external agencies, so that we can work together to treat the individual holistically without duplicating our services. So again, we're trying to eliminate silos where we can, and a lot of that comes down to our communication. So what we're essentially trying to do is ingrain clinical processes within our system to meet the client's needs, rather than the client needing to meet our clinical processes. So around the word, we throw around the word no wrong door approach quite consistently in our program, and we're really truly trying to create a system that takes that to heart and ensures that our clients are being able to navigate our complex healthcare system in a way that reduces any identifiable barriers to them, so that whether they join our service at RAAM and OGS, in the emergency department, or at our WMS system, they can move from one program seamlessly to the other. So it is a great idea in theory, but we have seen our fair share of barriers and challenges along the way. So what have we been seeing? The practicality of merging two teams together in a hospital system is very complex. There are lots of challenges that go along with it, and really it comes down to the complexity of the system. So I am the manager of both programs, and both programs have very different reporting requirements and need to be reported to very different agencies. So we need to make sure that we are blending our program structure while also being able to meet our reporting requirements, and that we are required to report on for our funding. So we need to ensure that we are continually tracking and reporting on key metrics so that we can continue to be funded. Those are the big areas that we've been seeing as the biggest barriers and challenges and things that we've been working on even to this day. An example really being that, for example, at HSN, our programs are working in three different systems. We have Meditech, we have BCare, and we have Catalyst. So ensuring that our staff are familiar with all of those and the right reporting requirements are getting in at the right time. Organizationally speaking, it sometimes feels like we're swimming up current. The system itself, based on these reporting requirements, is set up to be siloed. We have different staff working under different managers in different areas. At HSN, our addiction services are located in 3 separate locations. We have our inpatient environment, our outpatient environment, and our withdrawal management service separated by geography, by different managers, which really highlights the need for clear communication and clear streamlining of our pathways. We need to connect our clients in a way that is smooth and clear and as warm of a handoff as we possibly can, which really comes down to the need for clear internal and external communication so that our clients are receiving the best care and the right care at the right time. I'm going to pass it back over to Jared so he can talk a little bit about the clinic.
Thanks, Mike. So I wouldn't disagree at all with Mike in terms of the organizational or sector barriers, because they are what they are. But there are tangible day-to-day things that we've been looking to implement that have been kind of trying to change that patient experience. The first being space and how we imagine space, having multi-purpose space where it's not just, a room, for just an exam. It's a room where you could also do, a counseling session, or that you could hand off to your colleague, to continue or start something. Physical space is still needed, even though virtual technology has been a powerful care multiplier, I'm sure, for many people over the COVID pandemic. But having a reliable communication infrastructure has also been a really, really key thing. So depending on what your setup is for your EMR or how you're doing that, it may be easier or harder depending on your setting. But being able to have that kind of real-time communication and documentation for asynchronous delivery of care. So a social worker can see someone for a time, then have a nurse come in, and then have a prescriber at the end, or vice versa, depending on the capabilities or the flexibility of the team that day. So then in terms of the clinical staff itself, looking for ways to have standardizations has been really, really key. And you can read the rest of the points on this slide yourself, but the key kind of other one to highlight was a pivot to scalability rather than just simply, speed. So as demands continue to go up, the temptation can be, see more patients in a day, book shorter, intakes, or just be able to get more people through. And while I don't think, we haven't tried that, one of the things that we're really aware of is how can we work more effectively with our collaborative partners with built-in kind of press releases, if you will. And that's where collaboration, even outside of our own organization, has been really, really key and really, really an intentional thing. And we just even acknowledge for people on the call, I mean, not everyone's setting is going to be the same. You'll have more, fewer, less, better community resources or partners or inside your own organization. But that's been a key thing for us to be able to scale up or scale down based on our own clinical needs by having really strong collaborative partnerships with other organizations, or in our case, a lot of interorganizational programs that exist. But ultimately, it comes down to the patient's lived experience and how we deliver that service to them. And I'll let Alyssa speak to that.
Yeah, so what does this mean? We want to increase the odds in favor of recovery. So linking this to a committed mapping pathway. So we want to change that narrative to my team versus my worker, my doctor, my counselor, wanting to feel that they are part of this team, part of the recovery. Sometimes they know that it won't be they won't be able to see the whole team every time they present, but they know that person that they would like to talk to will get the message and they will get back to them. So that's security. In every appointment, you know, there's that chance to raise the needs for themselves rather than just sitting there with the uncomfortable, not being able to speak about their concerns and wanting and waiting for that right person. So being able to talk to, say, the RAAM navigator, the RAAM navigator can address that message to the nurse practitioner for the next appointment. And they can go to different care providers and not lose that team, not lose the RAAM team or OGS, open door. They're welcome to come back if needed, or if they're looking for other case management they can go to. So we're just trying to really change that narrative for the patients, trying to get their needs met at the right time. So I'll throw that one back to, I believe, Michael.
Thanks, Alyssa. So what are we tracking? We're tracking several things, but these are some of the key metrics that I thought I would just point out. One of the key ones being our ED admissions, our readmissions, our unique clients, and the number of visits that we're having. These are fairly common things that we've been tracking for quite some time. But again, we're trying to see if what we're doing is actually starting to have an impact on the larger system. Again, referrals out is another thing that is commonly tracked, and we've been tracking for some time. But we want to see if we're having any impact on where people are coming from and where we're sending people. The two more unique items that we're trying to track a little bit more closely are our shared clients. So how many clients do we have in between our two programs, and also our client satisfaction. Are they getting out of our service what they hope they are meant to get? The last thing I'll talk about is the 6 months, where we want to be in 6 months. So we are very soon adding a nursing role to our program. Specifically, a registered practical nurse will be starting in our RAAM program in the next few months, and we're hoping that will help us streamline a lot of our practices and take a little bit of the pressure off of our nurse practitioner, Jared, so that he can see more people. We're looking to actively engage with our community partners. One of the ones that we're most excited about is a safe consumption site that will soon be opening within our community, and we want to make sure that we have a close connection with them. We want to really create shared care programming within our program and with our partners. So we do have a good relationship with our withdrawal management service and our addictions medicine unit and our addictions medicine consult service, but we want to see that grow so that we can enhance our pathways and continue to communicate and really provide that true wraparound service for our clients. Lastly, we are looking at economies of scales, looking how we can better utilize the resources that we do have, because we are a small team seeing a lot of people within the year, and we want to ensure that our clients are getting the best care possible. Off to you, Jared.
Thanks, Mike. Just as we wrap up here, in the interest of time for some questions afterwards, putting a plan of place in the first appointment I think is a really key tenet of RAAMs. But we know that with the concurrent mental health, the trauma, that often that plan really does need to consider those aspects. And therefore, we're trying to put forward a model that, puts the two simultaneously as that shared first appointment. So the client is leaving with a prescription, but also with a clear onboard route, or even better, an appointment and now, entry into psychosocial treatment as part of their initial RAAM planning visits. So thank you for your time. And if there's any questions, we'd be happy to chat. I know there was one about barriers earlier, which was a great question.
Yeah, do you want me to read this out from A Smart? Apart from some of the already mentioned barriers, do you find any challenges in creating an appropriate mind shift for service providers to fully understand and embrace and finally practice this holistic and collaborative changes? I thought this was really interesting. I also was wondering, like, what would be the pushback against that holistic? Is it a reductive viewpoint? Jared, Mike, Alyssa, do you have any thoughts?
Yeah,
You want me to go first?
yeah,
Or
I'll
you
let
wanna
you go
go
first, Mike, because you get to see it at the management level as well. So yeah, it'd be a great place to start there.
I also don't want my lens to disrupt your thought process either.
No, it's
So,
okay. I've got my own opinion, so you go first. It's good.
so I would say that, and just from the feedback that I've received myself related to this, the biggest challenge is less about approaching the person in a holistic manner and more about the systems that are working, you know, that we're swimming upstream against. Switching between the reporting requirements that we have with OGS to RAAM and back again is a big challenge for a lot of the staff. We each have our own individual roles within the team, and we do follow those. There is some blending, and maybe the reason that I think that the approach has been received well is at the start of this, before we really went into it, we spent a little over a month visioning this out, like looking at it with the staff, planning it out, seeing how we could better approach our clients. And I think in retrospect, I feel like we've come a long way. We truly started this process in April of this year, and we kind of hit the ground running, but we've been talking about it since October of last year. So I'm not sure if my lens answered that question, but I'll pass it over to the other two.
Yeah, and just even dovetailing off what Mike was saying, just even going back to the metrics we're tracking. So there is pushback on some of those things, you know, the reporting requirements, the program things. But we're really hoping to get really high value data, specifically from, you know, readmissions, length of stay, kind of value dollar metrics, even, if you will, because it makes a very compelling case. You know, we're already seeing anecdotally, which is why Mike said we got to track this. We got to find out what the numbers are going to say. We're already seeing anecdotally, you know, our patients that are associated with this program aren't presenting in the same degree of crisis. They're not having those same escalations in their mood or in their substance use or their destabilization, because they're getting that approach. And that's kind of, you know, hopefully raising eyebrows or attention to say, okay, well then, you know, how do we model that and scale it? But there's also potentially a very compelling length of stay and readmission rate, which is often a very key data point that a lot of programs or hospitals or EDs are looking at.
Alyssa, do you have anything to add? I don't mean to put you on the spot. There is another question.
I know, just pretty much echoing with Jared and Michael were saying, we see some pushback, but you know, at the end of the day, we are seeing different programs specifically in the mental health side rather than addiction, where they are looking at more addiction workers, withdrawal management workers to help collaborate and to, as they can see the need for it. So yeah, that's what I feel.
I just want to remind everyone, there's one other question that I'll ask, but I want to remind everyone, I'm going to put in the evaluation in the chat. Please fill it out for the session and for the day. This kind of connects well to the last question from Diane, asking, how have you managed negotiating difficult program values and culture?
I actually didn't type it in correctly. I meant different. I meant different. Like
yes.
In our addiction services, we have different areas, and they all have their own culture, their own vision of what they're doing, their own value system, and there's a great deal of compatibility. But even just within our addiction services, I can imagine doing this would be like there'd be issues. So I was just kind of curious when it's
Great
different
question.
programs.
Yeah.
Mike, do you want to start that one first, or?
Sure. So to start, we were originally working out of different locations. So I mentioned earlier, we have 3 locations where addiction services were located, and we used the pandemic as is kind of like a little bit of an opportunity to move our RAM and our OAGS program together so that they could be co-located. And we've been using the team-based language since that started, but more formally started trying to bring the team together, as I mentioned last October, from a process and value perspective. I feel like I'm fairly lucky in the sense that most of our team sees the value in both sides of it, the medical model as well as the psychosocial model. And I think both teams are working together to try to meet that where we can. It hasn't been perfect. We still have a lot of barriers, but we're taking it one step at a time. So we're starting with RAM and OAGS. We're trying to, blend out for this pathway development into our other substance use programs, but also within our other mental health programs. We have challenges where we see people who are sent to us, with substance use, even though they want to work on something else, like their mood disorder, their anxiety, that type of stuff. So we start treating their substance use and then we start taking away their level of coping. So we've been working collaboratively with a lot of our other programs to try to shift culture. But it's not something that's done easy. And we have another poster presentation where we talked a little bit about that as well during that.
And that's,
I don't know if that answers your question.
I think that was a great response. And just as things are about to end here, thank you very much, Alyssa, Jared, and Mike. And thanks, Diane, for your question. Just a reminder again to please fill out the evaluations in the chat. And I think, Mike, you can catch that poster in the booth section, right?
Yep.
Okay, great. Thank you so much, everyone. We'll see you tomorrow.